Right, welcome back for the last session of this morning on Wednesday at ICAAD London 2019. My name is Christophe Sauerwein. I am the Academic Director of ICAAD and the CEO. And today it is my greatest privilege, pleasure, and honor, because I'm also a shrink and specialize in sex addiction, to welcome Dr. Stefanie Carnes. So thank you to be with us today, Stefanie. Today now and this afternoon to discuss more about females' specific problems. How can I describe your impressive career, Stefanie? I'm just going to stick to the guidelines here, I think. So, Stefanie Carnes, Dr. Carnes, you're the president of the International Institute for Trauma and Addiction Professionals, well known as ITAP, Training Institute and Professional Organization for Addiction Professionals. You are also a senior fellow for Meadows Behavioral Health, and I thank the Meadows for having made possible your flight over here. You also work with clients, which is very important because we can drown ourselves being academic sometimes, right? And so you also have a very, very strong field experience, which matters a lot. And in that respect, you are the clinical architect of the Willows house at the Meadows, which is a designed for relationship healing for women struggling with sex, love, and intimacy disorders. And you work there very closely. You're Phoenix-based, yeah.
Yes.
The other important thing here is that you are the author of a fantastic book about the partners of sex addicts, Mending a Shattered Heart, a guide for partners of sex addicts. We always forget about those ones. It's a very insightful book. And Facing Heartbreaks, Steps to Recovery for Partners of Sex Addicts, and Facing Addiction, Starting Recovery from Alcohol and Drugs. So this is about you, Stefanie. About us today, something happened in June. You may not have noticed it. The WHO made a fundamental decision. Sexual compulsivity, sex addiction, has been officially recognized as a diagnosable pathology after 10 or 15 years of endless discussion. So that's really central, and that's one of the things we really have to understand. And this is, I think, part of the topic you're going to address, Stefanie, in your presentation, which title is Sexually Compulsive and Addictive Behavior, the Controversy, Diagnosis, and Implications for Treatment. Welcome, Stefanie.
Greetings, everybody. It's great to be here in London. My passion is making sure that sex addicts and their family get compassionate and effective treatment, and I've made that a big part of my career. So as Christophe mentioned, I specialize in working with women, female sex and love addicts and intimacy disorders, and a lot with families, and have worked a lot with couples and family therapy for sex addiction. So I have about a 3-hour speech in about 60 minutes, so I'm gonna just go ahead and jump right in. What we're gonna be talking about today is some of the controversy around the diagnosis of sex addiction, why it's been so hard to get it into the DSM and into the ICD, some of the criticisms and some of the concerns, and many of them legitimate concerns that people have had about that, about the diagnosis. We'll also talk about some of the other controversial issues like sexual harassment, for example, and how that fits in with all of this, because that's also very confusing for people. So with that, I'm going to just go ahead and jump in. So I have a full disclosure slide as required. You guys have already heard my where I work. So one of the things that people don't realize is that non-paraphilic sexual addiction actually was in the DSM at one point. It was in the DSM-3R many years ago, and it was removed. And at the time, there was a lot of concern that it would be used in forensic cases, in court cases with sex offenders that would be used to get people a reduced sentence. And so it was pulled out of the DSM at the time. So since then, it's kind of left the field bereft of a diagnosis with a lot of discussion around what are we going to call this? Is this really addiction? Is this a real thing? So the most common terminology that we see in the literature is that it's either a compulsion, that it's an impulse control disorder, that it's an addiction, and some people have said, well, maybe we should call it like hypersexual behavior disorder, something kind of neutral like that. And so the field has been kind of arguing over this terminology. But if you look at the research literature around these different conceptualizations, there is actually a tremendous amount of agreement on what the symptom constellation is. So if you look at the different criteria people have used to conceptualize a diagnosis, there's really a lot of overlap in these different conceptualizations. And as Christophe mentioned, for the first time ever, the WHO made a very groundbreaking decision and put it in the ICD-11. Now, currently, they have put sexually compulsive behavior in the impulse control section of the ICD-11. So this is the diagnosis here. I won't read everything on these slides. One of the things that the WHO did is they've released some statements about their decision to do this. And one of the things they said is, currently there's an active science, this was in World Psychiatry, the #1 psychiatry journal last April. And it said, currently there's an active scientific discussion about whether compulsive sexual behavior can constitute the manifestation of a behavioral addiction. For right now, a relatively conservative position's been recommending that we don't have definitive information on, all of this. So basically they said, for now, we're gonna put it in the impulse control disorder section, and as research comes out, we'll see what's gonna happen. So they're saying basically, they're not sure that this is gonna be the final resting place for this diagnosis. And this is incidentally what happened with gambling as well. Gambling was initially put in as an impulse control disorder. So they're basically waiting for a little bit more research to come out before they make that final determination. Here's just a lay definition of sex addiction. Basically, it's a pathological relationship to a mood-altering experience that's sexual in nature that despite adverse consequences, the individual continues to engage in. And I'm going to use 10 criteria for sex addiction to describe it. And I have a lot of drawings from our patients to kind of share with you a little bit about what their experience is like and give you a little peek inside the world of their lives. So again, these criteria are similar to some of the other ways that this has been conceptualized. And I'll explain the differences in just after we discuss this. So the first one is that there's a loss of control. So there's clear behavior in which you do more than you intend to or you want to. So this was one of my female patients. She went to eating disorder treatment once and chemical dependency treatment 3 times before she finally came to sex addiction treatment. So this line here shows this is the part of her life that she was open about, and this is the part of her life that she would keep secret. So what she was doing is bringing the kids to school in the morning, and then at the time, Craigslist, are you all familiar with Craigslist over here? Was very, very active, and she would drop the kids off at school, get on Craigslist, go and do anonymous hookups, and do a lot of pain exchange on a regular basis, pain exchange sex, S&M sex with men that she didn't know. And it got to the point where it was very regular, and she was taking very high risks with her behavior. So you can see the out of control nature in this drawing. This was one of our male clients. He was also abusing alcohol. He had some confusion around his orientation, was married, and was acting out with a lot of anonymous sexual hookups. Spun a really wicked web of lies in his life around his behavior, which is very common in sex addiction to have the secret double life, which is part of the profile typically. We also see that the behavior is compulsive, that there's a pattern of out-of-control behavior over time, and it's used to reduce anxiety and medicate in some form or fashion. So this was one of our porn addicts. You can see here, he says, life sucks, so what is he going to do? Get on the computer. This is one of our female clients. So she had a very physically and verbally abusive father. He's sitting there saying, you're so stupid, you're worthless. This is how she feels inside. And you see she's got anger, loneliness, self-pity, self-loathing. So what does she do with that? But on the outside, she has a joint in her hand, her finger up to everybody, and there's the men all around her. You're beautiful, you're amazing, so sexy, damn girl. So you see how she's, taking that, difficulty with her self-esteem and getting what we call others' esteem through her relationships. This is also a porn addict here. We've got, and using cocaine and alcohol. So it says, broken dreams, no friends, no future, death, shame on you. And the devil says, I won you, bastard. So you can see from the drawing, obviously, it's a pattern that's gotten out of control. We also see a lot of efforts to stop, specific repeated attempts to stop the behavior that fail. So this was one of our clients that traveled for work. He was using a lot of prostitution, a lot of pornography, a lot of hooking up in different cities, ended up with relationships in different cities that didn't know about each other, and then finally ended up with 2 families that didn't know about each other. And so that made treatment complicated, I can tell you that. He ended up having 2 family weeks with his 2 separate families coming to treatment. And this client was a physician. He has sort of a sad story initially anyway. He was compulsively masturbating. He would masturbate up to about 8 to 9 times a day, very, very, very frequently, to the point of it was occurring between his office visits to try and reduce his anxiety. So compulsive masturbation is very, very difficult to treat, very difficult for people to stop. We had a client that just recently came in that masturbated in the taxi on the way to the airport, in the airport, in the bathroom, on the plane, in the bus on the way to the treatment facility, just to give you an example. So, this client was struggling with that type of compulsive masturbation. And so what he's depicting here is the lack of tools to be able to stop the behavior. He went to a sex therapist who told him masturbation is healthy, you can never do too much masturbation, which I agree masturbation is healthy, but there is a point when it can become compulsive for people. So, and he went to a group in which, unfortunately, a 12-step group, there was a lot of acting out in the group, so he ended up hooking up with somebody in the group. And so he tried many different ways to stop and get help, and wasn't able to get help until he got to treatment. So finally he did get treatment and get help. And this guy's just depicting his head in a vice to show how difficult it is to stop the behavior. We also see significant amounts of time lost doing and or recovering from the behavior. So this client just depicted addict time in real time, like it goes by at different speeds, because he spends so much time on porn and acting out. This client was a porn addict here, and you can see the grandfather clock as it's sitting there with the big frown on its face because excessive amounts of time being spent online. We also see a lot of preoccupation, obsessing about or because of the behavior. So this was a married man having 2 affairs, and you can see he's at his desk preoccupied with the affairs he's having. And it's a good example of out of control because he had, one affair is oftentimes hard to manage, and then he's going for the second, and so his life was really chaotic and unmanageable. And this client here is depicting his preoccupation. Whoops. Let's see. There we go. So you can see what's floating around in his mind here. You got the alcohol, the food, marijuana, and women, porn, kind of floating around in his mind there. Okay. We also see an inability to fulfill obligations. The behavior interferes with work, school, family, and friends. So this client is spinning his addictions on plates. One of the things you'll see in a lot of my drawings, lots of multiple addictions. Part of the reason for that is that because I run a group on that, and so I collect a lot of drawings in that regard. So we do have a lot of people with comorbid addictions, but it's probably a bit overrepresented in my drawings. So here he's spinning all of his addictions on plates here. So you've got gambling, cocaine. The computer represents pornography. the cell phone is work, and that's the one that's falling, and then marijuana. And there's his wife in bed like, where are you? And so often we have our clients that are, we talk a lot about intimacy disorders when we talk about sex addiction oftentimes, is because many of our clients, they're able to act out and, you know, have no problem, you know, being sexual with prostitutes or with porn and in other ways. But then when it comes to relationships that matter, they struggle. Not all of them, I would say like about 40%. So, you know, we also have people that, it's counterintuitive, but people that are aversive to sex in their relationships. This was a priest that came into treatment. You can see over here on the right-hand side the church, the sunshine, the love, and over here he was using mostly porn and prostitution. And you can see him, he's split in half. So that's that compartmentalization with a secret double life we were talking about earlier. So in recovery, what we teach them is that it's important to live in your integrity, live a congruent public and private life, let go of your secrets, and you know, have a culture of supporting you. It's a really important part. And when they do that and they get honest, then the depression gets better, the symptoms are reduced, the anxiety starts to go away, the relationships start falling into place. So that's a really critical aspect of treatment. The next one is continuation despite consequences, failure to stop the behavior even though you have problems because of it. So this was one of our females. So here's her husband walking out the door here saying, I'm done. And the kids hear, Mom needs help. And she's laying in bed doing drugs as one man, the next man comes over with vodka, pills, food. And you can also see she's bulimic. So she's, you know, got the eating disorder going as well. We have pretty high rates of comorbidity with eating disorders, especially in our women. This was an alcoholic prostitute user, so he would drink and drive and pick up prostitutes. And this client's just depicting the myth of Sisyphus, if anybody remembers their Greek mythology. He's going up the hill here trying to get to the Holy Grail, some sexual experience that's going to take his pain away and what have you, and every time he gets up there, another empty sexual experience that leaves him hopeless and depressed and hating himself, so what's he going to do but go back up the hill again? And so just that cycle there of destructive behavior. Escalation, need to make the behavior more intense, more frequent, more risky. So this is one of our female clients. She shares her cycle as she's kind of going downhill here. So you've got starting off with cigarettes, sugar, binging on sugar, then binging on sex. Here she falls in love, has a manic episode, more alcohol, a broken heart, marijuana, alcohol, sex. Here she is working until 11 p.m. at night, sleeping 12 to 14 hours a day, marijuana, mood swings, pharmaceuticals, eventually gets to shooting up to the point where she was like at death's door coming into treatment. So you can see lots of different ways that she's medicating there. And this client here is depicting his escalation here as he's about ready to fall off the cliff. This client is also drawing his escalation, so he is a crack addict, sex addict. So he's, the crack pipe here is pumping up his sex addiction like a bicycle pump. So you can see they're both escalating together. We also see a lot of losses, losing, limiting, or sacrificing valued parts of life such as hobbies, family, relationships, and work. So this was one of our female clients. Her 3 children were removed from the home just prior to her coming into treatment by social services. And so you can see here they're watching her as she's hanging herself on the tree of strip clubs and men and S&M and crack and porn and suicide and all of that. So now there was a happy ending to this. A year after treatment, she got out, she got her kids back. So there was a good positive end of that story. This client here is depicting his ritualization as part of his porn addiction. So here he is at work. He can't stop thinking about getting on the computer. He's preoccupied, can't stop thinking about it. He's doing what we call euphoric recall right here, where he sees the big smile on his face. He's like, oh, I can't wait to get home, can't wait to get on that computer. Gets in his car, goes over to the dealer's house, ding dong. Want a drink? Line me up. So he does some cocaine, buys the cocaine, goes over to Safeway, got my Jack, almost home, finally home, all locked up, and then he does the cocaine, the porn and alcohol till wee hours of the morning, till he's totally hungover, going to work the next day, and then he sits at his desk preoccupied with getting on the computer. So he's got this constant cycle that he's struggling with. Then lastly, we have withdrawal, which is stopping the behavior causes considerable distress, anxiety, restlessness, irritability, or physical discomfort. So this is one of our female clients here. You see the combination with her other addictions here. We've got alcohol, Diet Cokes, pizzas, so you got some binging and restricting with food going on. And when she has access to all this in the fridge, this is how she sees herself in the sexy red dress. So it kind of plays into her sex addiction. When she doesn't have access to it, she sees herself in a coffin. And this is one of our porn addicts just depicting difficulty with stopping pornography there. So those are the 10 criteria that we use. Now, where the addiction criteria deviate from the other conceptualizations is in the areas of tolerance and withdrawal. We probably won't have time to go into some of the research on that today, but there is some interesting research around those two concepts. There's some great research going on here in England at the University of Cambridge. You familiar with Valerie Voon's research? Anybody? A couple people? Yeah, so she's been doing great fMRI research on what's going on with addicts' brains when they're exposed to pornography. So for example, she's one of the most common types of studies that they've done in addiction research is to see how the brain reacts to cues in the environment. So for example, when a cocaine addict sees a line of cocaine, their brain lights up in a very specific way, which creates those strong cravings for them to have that drink right now. And so what she did is she scanned the brains of porn addicts and put them in the fMRI machine and showed them porn and looked at how their brains lit up, and it was very, very similar brain patterns. So she's done some very cutting edge research here on that particular issue. So I'm going to talk a little bit, we were going to talk about the controversy about the diagnosis, so I'm going to kind of step back and take a little bit of a time to discuss that. So back in 2012, there was a big push to try and get a diagnosis in the DSM by a gentleman named Rory Reed at UCLA. So he did the DSM field trial to try and get the diagnosis in the DSM. So basically what he did is he wanted to take these criteria, similar to the criteria we talked about, minus the ideas of tolerance and withdrawal. So pretty much the rest of the criteria very similar. And he wanted to look at, do these criteria work? Are they reliable? Are they valid? Given the same patient, would different therapists diagnose them in the same way? So he wanted to get inter-rater reliability. And basically, here's the criteria. You guys have access to these slides, by the way, so they're on I'm not sure how you guys have them, but I gave them to the conference for you guys to have. So you guys should have access to those. And basically what he found was he had 13 raters, gave them all the same criteria and the same patients to see if they got the same results. Gave them a lot of different testing. They were really properly trained. They scored, they even had blind raters. And basically what they found was absolutely the criteria worked, absolutely, without a doubt. So for those of you that are research buffs, it was like inter-rater reliability was 0.93, test-retest was high, sensitivity, specificity, positive predictor power. Really, you couldn't shoot a hole in it. Okay, it was very solid study. High concurrent validity with the other measures that were used. So they described the clinical course, all of the things that they needed to get it into the DSM. And they basically said, absolutely, these criteria can be reliably applied. However, it wasn't included. So the question would be why, right? And so he and Marty Kafka from Harvard wrote a paper on why it wasn't included. Does anybody want to venture a guess? Nobody? Okay. Politics. Okay. So basically, here's some of the things that were some of the concerns that were going on, and some of them, as I mentioned before, legitimate concerns. So behind the scenes, one of the things that was happening is the DSM editors were being openly criticized in the media, in social media, in many different ways. So they were specifically targeted, and and this still happens today when people try to publish and say that this is a real problem. Whether it be, any type of publications, we've had, for example, papers, people complaining that this is not a real problem and trying to get papers retracted, people saying that this is, not an issue, and so in the media and in mass, and so that is still very active. And one of the concerns is that the diagnosis will conflate social disapproval and morality with issues of health and disorder. So there's a lot of concern that we will over-pathologize people by making an actual diagnosis around this, which is a concern with many diagnoses in the DSM and a legitimate concern. We really do want to make sure that whatever criteria that we have is not creating false positives, not creating over-pathologizing people. The other concern that comes up a lot is that issue that we spoke about earlier about it being used forensically in court cases with sex offenders. There's still a lot of concern around that. Now, what Reed and Kafka said is really, they felt that was shouldn't have been an issue. They said there's really no evidence a pedophilia diagnosis has ever resulted in a reduced sentence. So do we really think that, including this diagnosis is going to? While others argue, well, actually, yes, it could. That maybe it could be used in court cases, and that could be, not something that we would want in terms of use of that diagnosis. Some people have said, well, how can we make sure that we're not just, calling people with high sex drives, sex addicts or hypersexual or sexually compulsive? Is there really a differentiation between people that are just, have a healthy sense of, high healthy sense of sexuality? And if we have a diagnosis, couldn't that possibly over-pathologize them? So Reed and Kafka argued that really the individual criterion were dissected and rejected while neglecting the fact that we really needed a constellation of 4 or 5 of the symptoms over 6 months would need to be present for a diagnosis. You also see that some argued that hypersexual behaviors are better accounted for by another already existing diagnosis. That's one thing that you'll hear a lot. Well, this isn't really compulsive sexual behavior. This is just anxiety and a symptom of anxiety or a symptom of bipolar disorder. But the research does not bear that out. So for example, this was a study that was done on a large sample of sex addicts, people that were inpatient for sex addiction, and they found about 38% did not have another comorbid condition, so that it occurred alone. So we cannot say that this is always, a symptom of another disorder, right? So again, some of the major concerns are that it's going to be pathologizing and that there's going to be a lot of false positives. The other concern that it gets brought up from time to time is that there's insufficient empirical research. Now, this is one that I kind of question at times because I have a database of articles on this with over 700 articles in the database. So I believe that there's a lot more research on compulsive sexual behavior than there are for many of the diagnoses that are already in the DSM, especially in the sexual disorders section like the paraphilias and things like that. So That is, that is a issue that I would, or a concern that I would take issue with. So that being said, we still are learning a lot about what's going on from a neuroscience perspective on that. So now one of the things that happened with the World Health Organization is they are very, they have done an excellent job with addressing some of these criticisms. So they are very aware of what the concerns are, and they did a very good job basically discussing these in some of their research journals. So one of the things that they said is early critics were concerned that any formal diagnosis would be used to pathologize sexual minorities and alternative sexual practices. However, to meet the diagnostic criteria for compulsive sexual behavior disorder, the problematic behavior must cause persistent marked distress or significant impairment in personal, family, social, occupational, or other important areas of functioning. Excuse me. In other words, the new diagnosis doesn't diagnose patients on what sexual behavior they freely engage in. It diagnoses patients based on impairment and distress. So if we did that, that would be like diagnosing an alcoholic depending on whether they drank scotch, beer, or vodka, right? It doesn't make sense to look at what behavior, it doesn't matter what the behavior is, it's their relationship to that behavior. And that's a really important distinction that they made. So that way, by keeping that in mind with the new diagnosis, that way it won't, pathologize sexual minorities and erotic minorities. They also said, excuse me, that distress that is entirely related to moral judgments and disapproval about sexual impulses, urges, or behaviors is not sufficient. So that's very important. So oftentimes I will have somebody outpatient, when working outpatient, that will come in and say, I think I have problems with, I think I might have an addiction to pornography, for example. Last month I looked at it and I felt horrible about my behavior. I still feel guilty that I did that, and I think I might be an addict. And this was, a month ago, 2 months ago, what have you. So, a lot of people will be what we call feel morally incongruent with their behavior and distressed around that their behavior doesn't match their values, but that doesn't qualify somebody for a diagnosis. Does that make sense? So we have to be careful, again, that we're not over-pathologizing people, that they are really, out of control, meeting the criteria so that, normal sexual behavior isn't pathologized. All right, so what do we do for a diagnosis since we don't have one? So we can use the ICD, which is 6C72. And right now, still, since we don't have something in the DSM, we are stuck with other specified sexual dysfunction is the recommended category. So we have a lot of common comorbidities with sex addiction or compulsive sexual behavior. And our most common ones are antisocial narcissistic personality, paraphilias, which I'm going to talk about in just a minute, ADHD, mood and anxiety disorders, PTSD, substance use disorders, OCD, and sometimes you can have cognitive disorders, like, for example, after traumatic brain injury or a stroke. It's a common neurobehavioral sequelae to that is sexually inappropriate behavior. So obviously that's a very different etiology, and so you wouldn't diagnose that as an addiction. So, as I mentioned earlier, personality disorders are a big issue in terms of treatment. We have about, in a sex addict sample, about 17% of clients meet criteria for a personality disorder, which obviously that can complicate treatment. And I'm going to come back to this in just a little bit when we talk about sexual harassment. We also have very high rates of ADHD in our population. So our clients are much more likely to have ADHD. Very high rates of multiple addictions as well. Alcohol is the most frequently co-occurring addiction at 46%. In gay males, drug abuse was a little bit higher, 54%. Gay males also scored higher on high-risk, dangerous behaviors. Women scored higher on compulsive spending, eating, and cleaning in this particular study. So we see lots of multiple addictions, as you've seen in a lot of the drawings I've shown you so far. So this is a client who's a workaholic coming home late from work. He's got the supersized McDonald's meal on the front seat of the car, the directions to Trixie's, which is the prostitute, the money flying out the window. So a lot of different behaviors coming together there. And I like the stop sign and the rearview mirror, my favorite parts of the drawing here. This client was a porn addict. This is Adderall here. He was diagnosed with ADHD. We have a lot of people that had been diagnosed with ADHD, which is holding up a pizza and his porn addiction. So he would basically restrict from eating while he was on Adderall and binge on porn, and then afterwards order pizza. It's kind of his typical pattern. And this client is playing whack-a-mole. Do you guys have that game over here? Okay, so it's like one addiction, he hits one addiction and another addiction pops up. All right, so when we're looking at our typical presentation of sex addicts or compulsive sexual behavior for our clients that come in voluntarily seeking treatment, we typically have very high rates of shame, lots of emotional and sexual abuse in the background. They're highly sexualized, lots of preoccupation around sex, lots of boundary failure. They tend to be more likely to be multiply addicted, less defended, very high potential for suicide, unfortunately. A lot of our clients come in on one-to-one suicide watches. We have to watch them very carefully. And fortunately, a pretty good amenability for treatment. These are very treatable clients. You know, they're very motivated typically and respond well to treatment. So this was one client's depiction of shame. So one thing I want to emphasize is just because somebody has had affairs, used prostitutes, attended a strip club, used porn recreationally, doesn't mean that they're a sex addict, okay? It's just as important to determine who is not as it is to determine who is. Again, we don't want to over-pathologize. So we really have to go back to looking at, do they meet those criteria? Are they using it to medicate? Is it out of control? Now, I mentioned before that the issue of paraphilias, that we have high rates of comorbidity. So we do indeed have high rates of comorbidity there. So the paraphilias currently that we have in the DSM-5 are exhibitionism, fetishism, frauderism, pedophilia, sexual masochism, sexual sadism, voyeurism, and transvestic fetishism. So right now, in order to meet the diagnosis for one of these paraphilias, it must include psychological distress and or distress, injury, death of unwilling persons or those of not of legal age. So let's say, for example, I'm into S&M and, you know, that's just, I enjoy that. I'm not, you know, I'm not out of control with it. I'm not, you know, I'm not hurting anybody. I'm perfectly happy with it. I wouldn't get a diagnosis, right? So, you know, you have to have that distress and that, or hurting somebody else as part of that diagnosis. So we do have overlap with our population. So you have some people that are just sex addicts, some people that just have paraphilias. So you might have somebody, for example, that has an arousal template for exhibitionism, let's just say. That's what turns them on, but they don't meet the criteria for a compulsive behavior, then they would be paraphilic, not sex addicted or sexually compulsive. Does that make sense? And then you have some that have an overlap, okay? So we have a lot of our patients that fall in that category with both. Now that brings me to this issue, which has you know, been a big issue in the States, and I think, you know, has hit the media a lot over here too. So a lot of times we see people with abuse of power, you know, saying that they are sex addicts. So that's been very common. So usually it's people like politicians, sports figures, religious leaders, CEOs, very wealthy people, abusing people that have less power than them. So this is the clergy and the parishioner, the teacher and the student, the doctor and the patient, the president and the intern, right? So. And so lots of common questions come up when this arises. So, a lot of people will use the terminology sex addict because that is the language of our popular culture, right? That people don't say I'm a sex offender or I have a paraphilia or I have hypersexual behavior disorder. They don't use that language. Everybody says I'm a sex addict, and that's what the media uses. So, a lot of people are concerned, is this really a problem? Is this an excuse for, bad behavior? Are there people that have, with this kind of behavior, that have a more sinister kind of profile, which we'll talk about in a minute? What's the difference between sex addiction and sex offending? Can these people really be treated? That's a big question that comes up. And if so, what's the best course of treatment? So one of the things that I would say, first of all, sexual harassment is offending, okay? There is a victim, an exploitation, and a lack of consent, okay? So that is not the same as a sex addiction. And but the media doesn't oftentimes make that differentiation, okay? So in these populations, we have, again, overlap. Unfortunately, our clients don't fall into tidy little diagnostic packages for us, right? They oftentimes are more complicated than that. And you may have somebody that actually has all three of these behaviors. So, and there's a lot of common features between, abuse of power, sex offending, paraphilias, and compulsive sexual behavior. So those include behavior that is distressful to self and others. They support their behavior with cognitive distortions. There's oftentimes a secret double life. There's serious life consequences. So in a lot of ways, there's a lot of similarities and a lot of overlap in these populations. So, but as I mentioned before, sex offending is not sex addiction. First of all, sex offending is a legal term, not a clinical term. So you have to be adjudicated in the legal system to be considered a sex offender. And when you look at some of the research, depending on what study that what study you look at, if you take a group of sex offenders and you apply the criteria for hypersexual behavior disorder or compulsive sexual behavior, only about 10 to 30%, depending on what study you're looking at, of offenders will meet that criteria. So there are a lot of sex offenders out there that do not meet the criteria. Okay, the vast majority of sex offenders do not meet those criteria. And as I mentioned earlier, it includes a victim, exploitation, lack of consent. Okay. So I've kind of hit that point here. One of the things, as I mentioned earlier, a lot of patients, they may present and have actually different issues, but they'll all call themselves sex addicts. So take, for example, a non-adjudicated sex offender. So somebody who's using child porn, for example, but hasn't been caught. That would be a non-adjudicated sex offender. They will oftentimes want to check themselves into sex addiction treatment, for example, and not think of themselves as a sex offender. Somebody with a paraphilic behavior with non-consenting victims, like somebody who voyeurs somebody, that's an offending behavior, right? Or someone with compulsive sexual behavior with non-consenting victims. So you can have somebody that's a sex offender, someone with a paraphilia, someone with compulsive sexual behavior, that all have consensual sexual behaviors that are predatory and offending, and they will call themselves sex addicts. So it's important for those of us that work in the field, and obviously they all just get sent to the sex addiction clinic, right? And so for those of us that work in the field, we have to be very careful about treatment and where people go, because a lot of times it's more appropriate for these for example, offenders to go to sex offender treatment. So like a good example, let's take the child porn case of the guy that using child porn that hasn't been caught. So in those instances, what could be better for somebody that's struggling with that than to be in group with people that have been caught, right? So it can be, they may benefit more from being in a group with other sex offenders. And so typically what we do is then refer them into a sex offender treatment program. Now, I don't know if you have this problem, but in the US, sometimes we have difficulties with that because the sex offender treatment is oftentimes based around third-party accountability, like monitoring and making sure that they live in certain places and have certain restrictions. And so sometimes some of the sex offender treatment providers won't want non-adjudicated people in their groups. That can be a problem, but we work hard to make sure that people that have an offending profile actually get the appropriate treatment. So are there times when people with abuse of power actually might have a compulsive sexual behavior? Sure. Again, we got to keep in mind the overlap. So this was one of my patients here. So you've got these are all the consequences he's experienced: divorce, loss of family's respect, loss of self-respect, loss of career. And basically how it started for him was compulsive pornography use and masturbation. That escalated to having affairs, escalated to prostitution, escalated to sex clubs, escalated to sex with couples, escalated to having orgies. Then he started having sex with people at work, and then eventually ended up having sex with his students. He was a professor. And so he crossed the line to abusing power. So he would fall in that kind of overlap area because he was totally out of control and compulsive. So again, it's sometimes we have to make some of these differential diagnoses, which can be a little bit tricky. Okay, so let me see how I'm doing on time. Okay, I have about 10 minutes. One of the things that is a really important consideration when looking at offending behavior and abuse of power is personality characteristics. And so one of the things that we watch out for is what we call the dark triad personality characteristics. Obviously when you're working with people with offending and types of behavior, you have to be mindful of characterological issues. And so the dark triad is where you have narcissism, psychopathy, and Machiavellianism, which basically presents with a client that is very impulsive, emotionally cold, remorseless, grandiose, perceives himself as superior, entitled, manipulative, self-interested, and domineering. So obviously you have that. If you have that personality profile, that makes for a difficult prognosis, right? So, and we see this oftentimes with exploitation and abuse of power. For example, with our narcissistic clients, it's not uncommon for them to be triggered, have their ego, they oftentimes have fragile egos, they'll have some ego degradation, and they'll experience that shame and unworthiness, and which increases their entitlement, their sense of entitlement, and so they will act out putting another person down to make themselves feel better, right? So that looking at what role their personality plays in with their sexual behavior is important. And if you look at, this is two different studies, but I'm putting them side by side because when I read this, I thought it was very interesting. So one study was on sex offenders using the SCID, how many people, same instrument, how many people that out of sex offenders met criteria for personality disorders, and you had 73%. Now with sex addicts and out of a sex addiction clinic, so these are voluntary treatment seekers that check themselves in, okay? 17%. So you see very different profile. So if they come in for help on their own and they don't have those personality profiles and they have high shame, high remorse around their behavior, that's a much better prognosis for that patient. So poor prognostic indicators for us are things like dark triad personality characteristics, being forced or coerced into treatment, lacking remorse, shame, and empathy, a history of other types of offenses or assaultive, violent tendencies, other types of unethical behavior, like financially unethical behavior, that type of thing, other types of impulsive behaviors, a lack of openness, lots of defenses, and evasion of consequences. So as you can imagine, that kind of presentation is going to be a much more difficult presentation. Right? Okay. All right, so one of the things I often advocate, we have in our field of sexual health, we often have people that will treat offenders, people that will do sex therapy and treat paraphilias, and people that will treat addiction and compulsive behaviors, and oftentimes they're not cross-trained. And I think it's so important that we need to break down these silos and really start learning from each other in terms of treatment and really start cross-training our sexual health providers. All right, so I am going to just pause here. I have about 9 minutes left, and I'm willing to bet there's some questions, and I want to be able to answer some questions. So does anybody have any questions? Yeah. Yes.
I mean, could maybe see like characteristic tolerance withdrawal with the brain?
Yeah.
It's going to be that same pleasure reward center.
Yeah. If we had a little more time, actually, I have some citations that are in this packet. So if you read a little ahead, there are numerous studies that are fMRI studies that show evidence for tolerance. So it's, a lot of times our clients will say, they need more and more porn to get the same effect, or you see this escalation that comes over time. Now, when it comes to withdrawal, one of the things that's very confusing for people, one thing that you'll hear sometimes is, well, sex can't be an addiction because there's, you can't go into withdrawal from it. So that's actually a misunderstanding of addiction as well. So dependence and addiction occur in different areas of the brain. Dependence is in the brainstem and in the thalamus. And so that's why and addiction occurs in the reward center. So that's why you can, for example, go to have surgery and be medicated as prescribed on pain medication in a hospital, and actually become dependent and have to be titrated down off your pain medication, but not be addicted. Okay, so you can become physiologically dependent on something and not become addicted. Addiction comes when you do more and you do more and you blow out that dopamine system, and it's a totally different process in the brain. If you want to learn more about this, there's really good graphs on this on the NIDA website, National Institute for Drug Abuse. Just look up dependence versus addiction. So that's why, for example, you can be a cocaine addict and not go into withdrawal. That's why gambling is an addiction and you don't have withdrawal. So there's a lot, you have a psychological withdrawal, and oftentimes you have dopamine downregulation that makes you feel distressed and irritable when you can't access your addiction of choice. So it's actually two different areas of the brain. And so it's confusing for people. You hear that a lot. Well, sex can't be an addiction. You can't go into withdrawal. Totally different areas of the brain. Yeah, good question. Thank you.
You said earlier about you follow the 12 steps. Is that the same as 12 steps for addiction in drug and alcohol? Because during the 12 steps, part of it's remaining abstinent from it.
Great question.
So is that the same for sexual addictions
No,
too?
it's not. So recovery from sex addiction is more like recovery for an eating disorder. You have to learn how to have a healthy relationship with your sexuality. Otherwise, becoming sexually aversive is not a positive sex health plan, right? And so basically we use what's called a 3-circle method, in which people really define there's 3 different circles. The inner circle is these are the behaviors that have gotten me into trouble, then I'm not going to do those. The middle circle is boundaries that you're going to have, so I'm not going to drive down the street where the prostitutes were, I'm not going to have an unfiltered computer. And then the outer circle is your healthy sexual behaviors. So each person's sexual health plan is individualized for them depending on their needs. Yep, yeah. Thanks, Christoph.
I had two questions. The first one is, you mentioned ICD-11. So has the ICD-11, which is not out yet, have they coded the hypersexual behavior disorder?
Yes.
They have.
So it's compulsive sexual behavior disorder. It's in the impulse control disorder section.
Okay. And the other question is, what are your views on tolerance in hypersexual behavior?
So I certainly, as I mentioned earlier, there is certainly some research evidence. It's still new. There is some, like Simone Kuhn's research. If you look at the reference, there's some quotes in her research that talk about tolerance. In this packet, I can actually page forward a little bit. Bear with me. Okay. So this, she looked at this and she said basically that what she showed is higher hours of porn viewing, more years of porn viewing, correlated with reduction in gray matter in sections of the reward circuitry. Now that particular finding's been a little controversial because there have been other studies that have not found that specifically. Which was led to what she found. And then she says this translates into a sluggish reward activity or a numbed pleasure response desensitization. So basically she says this could mean that regular consumption of porn more or less wears out your reward system, and we assume that subjects with high porn consumption need increasing amounts of stimulation to receive the same amount of reward. So kind of, again, this is a new area, looking at the issue of tolerance. There's still not a whole heck of a lot of studies that focus on that in particular. Yeah. Yeah.
To get the right glasses on so I can read my own notes.
Okay.
I was just thinking when you quoted the 38% in the Reed and Kafka study that don't have a comorbid disorder.
Yeah.
I'm sort of wondering, I was reading in terms of the etiology of sexual addiction, and it talked about opportunity, trauma, and addiction. Mm-hmm. And it's curious that they have within their figures something like, I'm talking about Laurel Centre research here in the UK, but just under 40% are opportunity only. And I sort of wondered, does it sort of speak something about the changing nature or the profile of addicts because of, new technology and smartphones and so on and so forth? And is this actually, what we're going to see more of? Less comorbid disorders, less, early childhood issues or attachment issues?
Yes.
And more opportunity-based addiction?
I would say yes. What we're seeing in the younger generation, so right now in the research there is a bit of a distinction in the literature that looks at what they call classic sex addiction versus contemporary sex addiction. And so the classic sex addict is the multiply addicted, highly traumatized, attachment disrupted kind of client profile. But one of the things that we're seeing in our younger generation is the contemporary sex addicts have typically early exposure to porn, lots of graphic online content, a lot of kind of this growing up in this environment where casual sex and, sex apps and hookups is the culture is very trending towards more non-relational sex. And what we're seeing, and a lot of porn addiction in that group. And so we're seeing people, our younger people having less trauma, less history of trauma. Now, some people argue, well, isn't being exposed to porn when you're 8 traumatic? So depends on how you look at that. And more secure attachment. So basically, some people are just getting online and getting in trouble just with their, the addictive nature of porn, and don't have some of that history. So I would say absolutely. Mm-hmm. Okay, this is going to have to be our last question.
Thank you very much. Please could you prophesy what might happen in the future? The diagnoses are very convenient. You mentioned politics. The diagnoses allow us to continue demonizing sex offenders. So it fits very comfortably with the current political situation. In a more idealized world, in the future, how would you imagine less separation between the offenders and the addicts? I.e., simply we would concern ourselves with damage caused to other people, whether it was legal or illegal.
Okay, so I'm hearing kind of two questions there. One is, can I prophesy about what's going to happen with the diagnosis? And two, how will that impact offenders, and will it help us to demonize them less? Is that, am I getting that?
Yeah, the current separation between offenders
And addicts.
allows us to continue demonizing offenders.
Yeah. So, okay, so the first part of that question, I think eventually the DSM will give us a diagnosis. There's still a lot of, there is a small group of people, but in the US, researchers that are very actively trying to oppose the diagnosis from getting in there, but there are also a lot of people trying to get it in. So it's still a very active debate in terms of I'm just talking about the DSM now. But I think now that the ICD has put it, legitimized it as a disorder, then it opens the door for the DSM to do the same. So hopefully that will happen. And also the World Health Organization published a paper about 2 weeks ago that said that they were developing a category for addictive behaviors, that they are moving gaming and gambling into, and substance use disorder. So they are going to have now a category for addictive behaviors that has some behavioral addictions in it. So that also could be a home for compulsive sexual behavior disorder at some point. So we'll have to see what happens and how that unfolds. Now in terms of depathologize, will that help to depathologize sex offending? I don't know. I don't know if that will, because I think that, sex offender treatment, sex offenders face their own, stigma around their behavior. And I don't know that, as addicts do as well, but I don't know that having a diagnosis is going to reduce that stigma that much because of the the exploitation and victimization of other people. I think people still have a very strong reaction to that. But, I think there can be more understanding about what plays into that, like trauma, oftentimes attachment issues. So educating about that, I think, would be helpful. Mm-hmm. All right, well, thank you all very much.
Thank you, Stefanie.